I'm really excited to have a chance to share with you some of the work that I've been doing with my graduate students and collaborators for the last few years. My research is in fundamental human cognition. In my lab, and occasionally outside of the lab, we study the acquisition, retention, and application of complex knowledge. Our aim is to take those research findings and transform them, first into a model of expert development, and then into plans for curricular design that can be applied across the health professions. The core of my work has been for a very long time trying to understand the role of basic science in medical cognition. Specifically, we've been really focused on trying to identify both the structure and function of biomedical knowledge in the mental representation of novices. So today, what I'm hoping to do is share a little bit with you about our basic model of human cognition, and then use that model as a foundation to discuss implications for clinical reasoning and practice, and for curriculum design. This process of beginning with cognition is something that I think we often overlook and take for granted a little bit in medical education and in education research. Across the continuum from undergraduate to postgraduate to continuing education, we often make the mistake of starting with the curriculum, or sometimes we focus exclusively on context. We write objectives and we debate pedagogical approaches and we create assessments, often with little or no attention to the basic processes involved in human learning. So today, I'd like us to return to the basics and really think about the fundamentals of human memory, categorization, and learning, and how we can use this information to advance medical education. The main focus of my work has been to better understand the development of and interaction between two forms of knowledge: basic science knowledge, biochemistry, anatomy, physiology, these types of things, and clinical knowledge, the signs and symptoms of disease, both of which have to be acquired, retained, and applied during clinical reasoning. Of course, there has never been any doubt about the importance of clinical knowledge in medical education and the value of clinical knowledge in medical training. We expect our students to be able to master all of the clinical content needed for successful practice. And frankly, we'd be shocked and appalled by experts who sometimes miss obvious signs and symptoms. Questions around the value and specific impact of basic science knowledge, however, have been around for more than 100 years. There are always concerns about how much basic science should be included in the curriculum, when it should be included, and how it might support or hinder the acquisition of knowledge that seems more directly linked to patient care. I mean, who really needs the Krebs cycle anyway? We can find answers to some of these questions by shifting our attention away just for a moment from the shiny objects in the curriculum to thinking a little bit more about the fundamentals of human cognition. Studies of memory and categorization and attention and awareness all suggest that integration of basic and clinical science will be quite valuable in helping students organize, retain, and apply their clinical knowledge and better solve clinical problems. An example of this work is a study that was done by Miriam Baghdadi. As part of her doctoral thesis, Miriam looked at clinical reasoning in oral radiology. She randomly assigned dental students from the second year program at University of Toronto, as well as the dental hygiene program at a local community college, to learn 4 different oral abnormalities. The participants in her basic science group learned all of the radiographic features of each disease, and they also learned the underlying mechanism that explained why each of those radiographic features occurs. The participants in the structured algorithm group learned the same radiographic features as the previous group, but without the basic science. These students are not provided with the mechanism of disease. Instead, these students learn a general algorithm that helps them analyze the lesions, and then they learn to apply that algorithm in order to recognize the appropriate diagnosis for each X-ray. This is an algorithm that we chose because it was really developed by University of Toronto faculty members and distributed across the world in one of the most popular textbooks. Students in her feature list group learned only the radiographic features of disease. So no basic science, and they weren't given any particular way to organize or understand the information. All of the learning materials are presented to the students on personal computers that present audio slides and accompanied audio recordings. Nothing fancy, nothing fun. Our aim here really is to just study the cognition in isolation. The participants then complete a series of tests designed to measure acquisition and application of knowledge. For each condition, we have a customized comprehension test that looks at their understanding of the basic science for the students in the basic science group, their understanding of the algorithm for students in the algorithm group, and their recall for the clinical features in the radiographic feature group. In the diagnostic test, students complete 28 x-rays and determine the most appropriate diagnostic category for each. They do not have to provide a justification or any other information. Common across all conditions, participants complete a recall quiz that looks for straightforward memory of the radiographic features for each disease category. The participants then go away for a week and return to the lab to complete a novel diagnostic test and a novel recall quiz without the opportunity to review the material beforehand. What Miriam found was that participants in the basic science condition significantly outperformed those in the featureless condition and the algorithm condition. And this is true on immediate testing and after a 1-week delay. What these data tell us is that the integration of basic science is important. Unlike an algorithm, which might provide some organization of clinical knowledge, the integration of basic science supports clinical reasoning by changing how the learner is actually able to use their knowledge to diagnose a clinical case. An algorithm might be sufficient for some tasks, but it clearly doesn't support longer-term diagnostic reasoning or retention and memory. This study is just one of a number of studies that we've done using similar protocols in different disciplines. So we've done studies in dentistry, in neurology, in rheumatology. We've looked at procedural skills acquisition. And all of these studies have helped us better understand the impact and value of this form of knowledge in clinical reasoning. We have shown that the integration of basic science can lead to improved diagnostic accuracy. We've also seen that when we challenge students with cases that are novel, ambiguous, or complex, we see that basic science knowledge helps participants make sense of the clinical signs and symptoms and arrive at the correct diagnosis. Taken together, these studies really emphasize the role of basic science knowledge in acquisition, retention, and application of a key clinical skill. As an exploration of medical cognition, these data are really helpful in creating a clearer picture of the function of basic science knowledge. From an education standpoint, a key tenet of medical education has always been that the basic sciences are foundational. They're intended to be the knowledge on which later knowledge and experiences can be built. When we think about this only at the curriculum level, our attention can really be drawn to questions around when students need their basic science knowledge. When should they encounter these particular subject matter? What sorts of assessments should we use? But I think that's going a step too far. If we take a cognition-focused standpoint, the issue is not when, whether it's first year or second year or fourth year of residency, but in identifying how the acquisition of one form of knowledge can enable the acquisition of additional knowledge. To study this, we adapt an experimental design originally created by Bransford and Schwartz and used to examine preparation for future learning. The design involves providing students assigned to 2 different forms of instruction an opportunity to learn something. They then complete an initial assessment that looks just at their memory for that initial learning phase. This is followed by a common learning session in which both groups are challenged to learn something new using the same instructional format. This is then followed by the preparation for future learning assessment. In our study design, we compared students who received basic science instruction on 4 broad categories of neurological disease to students who learned only the signs and symptoms of those categories. We anticipate that students who learn the basic science mechanisms will be better able to use that knowledge to learn novel related disease conditions than students who received clinically focused instruction. What we found was that while both groups showed the same level of performance on initial learning, students in the basic science condition outperformed those students with clinically focused instruction on the preparation for future learning assessment. It's their understanding of basic science mechanisms that served as a stronger foundation on which they could build their new learning. So we're getting closer. we can start to see the function of basic science knowledge in acquisition, in retention, and in future learning. But I promised a story about cognition. What about the mental representation of knowledge? We've conducted several studies in which we manipulate the presentation of basic science content in order to really hone in on the structure of knowledge in novices. In one example, we had 4 groups of students who learned 4 different categories of neurological disease. Students in the integrated instruction condition learned the disease features along with an immediate presentation of the causal mechanisms. So imagine a set of lecture notes that were written out line by line. For each mention of a clinical symptom, we immediately present a basic science mechanism in the very next sentence. For participants in the basic science first condition, we present all of the basic science content up front, followed by the clinical features. In the clinical science first condition, we again pull the basic science and clinical information apart, but this time it's the clinical features first, followed by the basic science. In our clinical only condition, we present just the clinical features in isolation. What we really want to focus on is the value of that really tightly integrated sentence by sentence instruction. What we see is that on immediate testing, there's no difference between the groups. Participants in all 4 conditions are able to learn to adequately diagnose the 4 conditions. However, when we look at how the participants perform after the 1-week delay, what we see is that the biggest degradation in performance come from those 2 groups that had the basic science and clinical content pulled apart. The students in our fully integrated instruction outperform all of the students in the other groups, and the students in those groups where the information was not presented in that tightly connected way actually perform the same as if they had never learned the basic science at all. Taken alone, all of these studies can feel like one-off demonstration projects. But if we put them all together, we can use all of these different experimental findings to paint a really clear picture around the mental representation of knowledge. Medical diagnosis is really just another version of a basic categorization task. So to efficiently and effectively store information in memory and make categorization decisions, humans rely on the development of a coherent, tightly connected semantic network. You can think of all knowledge related to any everyday category as being organized in a semantic network. It's a set of abstract concepts and specific experiences tied together in memory. The goal of medical education is not just to give students basic facts, but to actually help them develop an integrated understanding of basic science knowledge and clinical concepts. All knowledge, both basic science and clinical, must be stored into a coherent semantic network in order to be used. We develop concepts and categories and meaningful connections between members of those categories through our educational experiences. A semantic network always contains 2 key components, the nodes and the connectors. In diagnostic categories, the nodes are the clinical features and the connectors are the basic science mechanisms. We know from decades of work in everyday cognition that the connections are literally the most important part of the network. They keep the whole thing tied together. Without the connections, will clinical features just exist as isolated nodes that are difficult to recall and can't be used to solve clinical problems. We also know that connections are dynamic, they're idiosyncratic. They change, they grow, they move. They can be stronger or weaker depending on the degree to which an individual associates 2 things in memory. So you can develop strong, powerful, durable connections or weak, fragile, meaningless ones. Depending on the way we structure an educational experience, students can develop strong basic science connections or weak ones. This model of medical cognition and knowledge gives us a new lens that we can use to understand efforts at curriculum design and curricular integration. I know that integration is a buzzword right now, and when you look at the literature, you see a lot of different uses for the term and a lot of different approaches to integrating content across various schools. Our review of the literature revealed a lot of integration happening at the level of the program. Often this involves bringing curricular content that is clinical into the first 2 years. This could be as early as the first day of medical school. Occasionally, it means adding more basic sciences into the clerkship years. Both approaches are reasonable, but we have to ask whether these efforts will really result in students developing a coherent mental representation, or if we're just helping them lay down more isolated nodes. Similarly, we see a lot of integration at the course level. This can include shared teaching models, courses that offer back to basics instruction, where both clinical teachers and basic science teachers work together to create the content. Again, these efforts are admirable, but it's unclear that this will lead to the same positive effects that we found in the lab. From our standpoint, integration really needs to be understood as a cognitive activity. It's something that occurs within the mental representation of the learner, not only in the curriculum. This is an incredibly freeing definition of integration. It means that we can make changes at the session level, changes to the words the teacher says, the lecture notes, the test bank. Minor changes to all of these things can lead to large impact when it comes to cognitive integration. It also means that we can change our very definition of basic science. If the role of basic science is to create coherent mental networks, then we're not really limited to biochemistry, anatomy, or any of the traditional biomedical sciences. If we look at it this way, almost any form of knowledge that provides mechanistic or causal relationships or can explain why can be considered a basic science. And then that knowledge becomes foundational to the practice of medicine. We've observed this broader understanding of basic science both in and outside of the lab. We initially conducted an ethnographic study in a complex care clinic. We looked specifically at the performance of integrated CanMeds roles. So we observed residents while they were interacting with patients, with faculty, with various members of the care team, and we noted moments of integrated activity. So those times in which residents were performing multiple CanMeds roles at the same time. And what we found was in those moments, they were also integrating different forms of knowledge in order to aid their decision and actions. This included system science, knowledge around access to care issues, humanistic considerations, the social determinants of health. All of these forms of knowledge represented for us the context of clinical reasoning. And so while our laboratory studies isolated the effects of cognition from the context of practice, this real-world investigation really helped us see the same cognitive mechanisms at play. It's this integration of knowledge in context that we have defined as the hallmark of medical expertise. This suggests that we can expand our definition beyond biochemistry and anatomy. In a recent study, we explored this further, returning to the lab, by randomly assigning students to one of two groups to learn 4 different medical psychiatric comorbidities. Again, using the double transfer design created by Bransford and Schwartz, we compared students who learned clinical signs and symptoms to those who learned underlying mechanisms. The key difference with this study is that we drew our mechanisms from a wide array of sciences to create those coherent connections. We used mechanisms from psychology, evolutionary biology, sociology, and biology, of course, to help students understand why the comorbidities arose. We anticipated that students who learned these mechanisms of disease, regardless of which science the mechanisms came from, would be better able to learn novel related conditions than students who learned only clinically focused instruction. As predicted, the students who were taught using this expanded definition of basic science were better able to use that knowledge to acquire new knowledge in the preparation for future learning instruction phase, and they outperformed students in the other condition on the PFL assessment. So what does this all tell us about the curriculum? Taken together, this work suggests that we need to foster cognitive integration through careful design of educational tools, strategies, and techniques that are meant to support integrated understanding. In some cases, this might involve careful creation of PBL tutorials, CBL, TBL, whatever PBL you want to use. In other cases, it really just might mean a straightforward didactic lecture. Our focus really isn't on the format or creation of a particular program. It's really on the format and creation of a specific cognitive structure. I admit that a didactic lecture isn't always the most appropriate choice for a number of reasons. But there is little denying that if done correctly, a carefully constructed lecture can support integrated understanding. What matters more than the format of instruction is that the learning experience is designed to create those meaningful connections and coherent semantic network. It's important to keep in mind, however, that meaning is always in the eye of the beholder. Left to their own devices, students can misinterpret or dismiss underlying mechanisms. It's really the job of both clinical teachers and basic science teachers to construct meaningful causal connections for clinical manifestations. Using this basic premise as our guide, we can adapt medical education accordingly. So whether it's PBL, a didactic lecture, or a virtual seminar, an emphasis on integration and the creation of meaningful connections really should be at the heart of medical education. This cognition-focused approach is a first step towards designing an evidence-based curriculum. And I'll admit it's a small step, but I think it's an important one. It's one that really gives us an opportunity to open up a huge design space for innovation in curriculum, innovation in curricular design, and even innovation in assessment. I think that this focus on fundamental human cognition is something that, again, we sometimes overlook. But taking a minute to go back to basics and thinking a little bit about our fundamental mechanisms of human learning, human memory, human attention, human awareness, all of these small pieces that we have decades of literature to help us guide and make our decisions, these are things that I think if we take a little bit more time to review, we can make huge gains in basic science integration and across the curriculum. I'm hoping that by now you are fully prepared to think about how we can use this information to design new instructional strategies and tools. And so I think I will stop there and thank all of the graduate students and collaborators who collected all of this data and helped us put together all of these studies and have really pushed my thinking on the topic for years. I'd also like to thank the funders who provided the funding for the various studies, as well as all of you for taking the time to listen today. Thank you.